So I was actually going through the channel to see which videos I have done or haven't done, and actually realized that I haven't done anything on inotropes, be it in internal medicine, be it in pediatrics, and I thought this is a very good stepping stone for us to learn about inotropes and how to do the calculations, especially with dopamine, because this is one of the drugs that you're going to be using day to day when patients coming in shock or in hypotension. So grab a piece of paper, grab your pen, and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at dopamine calculations. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Drop a comment, drop a like to Zambia and beyond. Let's go. So remember that dopamine is pretty much occurring naturally in the body, and it's going to be found in the CNS. I'm going to be writing some notes here for you guys to follow. So it's going to be found in the CNS. Okay, so it's found in the CNS. Predominantly, it's going to be found in the basal ganglia. Remember when you're talking about those pathways in the basal ganglia that has to do with the motor system, we got to learn that you have some dopamine that is present in that area. It's also present in the medulla. So we're going to be having these dopamine being produced in the adrenal glands. So it's going to be produced in the adrenal glands, specifically in the medulla. So this is going to be specifically in the medulla, because remember that the adrenal glands have predominantly two sites. They're going to be having the cortex, they're going to be having the medulla. So remember that this dopamine that's going to be produced is going to be a precursor of, or an immediate metabolic precursor of norepinephrine. So it's needed for synthesis of those catecholamines, and it's going to have predominantly some effects on certain types of receptors on the body. So it's going to be having predominant effects on alpha receptors. So it's going to be having predominant effect on alpha receptors. It's going to be having predominant effect on beta receptors. So it's going to be having effect on beta receptors, and it's going to be having its effect on the dopamine receptors. So it's going to have effect on the alpha receptors, it's going to be having effect on the beta receptors, it's going to have effect on the dopamine receptors. This is very important for you to actually note. And remember that the effects of dopamine are going to be dose dependent. So another thing is that they're going to have this dose dependent effects. Okay, so you have this dose dependent effects, meaning that at certain doses you're going to be seeing certain effects in the body, while at other doses you're not going to be seeing other effects in the body. But generally, what are the effects that we're going to be seeing of dopamine? So the first and foremost thing is that it's going to be having a vasopressor effect. So it's going to be having a vasopressor effect, so meaning that it's going to be causing vasoconstriction. In addition to this, it's also going to be having a positive inotropic effect, positive inotropic effect. So it means that this vasopressor effect is going to be resulting in pretty much an increase in your blood pressure. So there's going to be an increase in your BP. So you have this increase in your blood pressure. You are going to also have this increase in your systemic vascular resistance. So you're going to have the increase in the systemic vascular resistance. You're going to be having an increase in the cardiac output. I'm not going to be going over those pharmacology of how cardiac output affects blood pressure, how systemic vascular resistance affects blood pressure, because I already did a video on hypertension, and I'll leave it tagged at the end of the video so that you can actually watch how these things are relating to each other. So this is just pretty much an overview or a summary of the topic. So in addition to this, there's going to be also an increase in contractility of the heart. So an increase in contractility of the heart. So it means that the heart is going to be contracting even more. So this is at the usual doses. So at low dose, so let's say our second effect here at low dose, it actually has a vasodilatory effect. So it's going to be causing some vasodilation, but it's not in all types of arteries that this vasodilation is happening, but predominantly we're interested in the kidneys. So at low dose is going to cause vasodilatation of the renal vasculature. So it means it's going to improve renal blood flow. So keep this in mind. And remember that our dosage of the dopamine is going to be given in micrograms per kg per minute. So it's going to be written as follows. So micrograms is, I'm going to be writing micrograms as mcg per kg per minute. So that's going to be, our dose is going to be given in micrograms per kg per minute. I don't know what's happening with my PC, but it's glitching again. So this is going to be micrograms per kg per minute. That's going to be our dose that we're going to be using. And then another thing that I want you to keep in mind as we're doing these calculations is that 1 milligram. So do not confuse micrograms with milligrams, because micrograms is mcg, milligrams is mg. So 1 milligram, which is bigger than micrograms, is going to be equal to 1,000 micrograms. Okay, so this is going to be equal to 1,000 micrograms. This is a very important thing to actually keep in mind, these conversion factors. And then also remember that 1 hour, I think this one is safe to say that most of you that are watching the channel already know this conversion. 1 hour is going to be equal to 60 minutes. So I want you to keep this in mind, that 1 milligram is going to give you 1,000 micrograms, and then 1 hour is going to be giving you 60 minutes. So keep these conversion rates in mind. So our route of administration for our dopamine is pretty much going to be IV, but generally we want to be giving it via a central line. The reason why we're giving this via a central line is because sometimes the drug can actually extravasate from the blood vessel, and once it extravasates and has this vasoconstrictory effect, this may actually lead to vasoconstriction of the tissue. It may lead to tissue death, so it may lead to this tissue necrosis. So you must be checking the IV sites of wherever you're going to be administering this dopamine, because there is a high risk of this tissue necrosis. And remember, once this has happened at the infusion site, you want to give an antidote. So our antidote that we're going to be giving to combat this negative effects of dopamine is pretty much a drug that we refer to as phentolamine. So a drug that we call phentolamine. So once we notice that there is some adverse effects of the dopamine, we can actually give phentolamine, which will cause some vasodilatation. And remember, for all patients that are actually on the dopamine infusion, we have to make sure that we continuously monitor the ECG, because the dopamine has a risk of having these tachyarrhythmias. We also want to continuously monitor their blood pressure. So the things that we're going to be monitoring is that we're going to be having a continuous ECG monitoring. We're also going to be having a continuous blood pressure monitoring. So we're going to have a BP monitoring, a BP profile. We're going to be having ECG monitoring, always for patients that are actually on dopamine infusions. So what are the usual doses that we actually give these patients? So I'm going to start with the adults. So this is pretty much for adults. On the pediatrics, I will do it in the next slide. So remember that we can divide the dosage into what we call according to the certain effects to which the drug actually has. So if we have about 0.5 to about 2 micrograms per kg. So micrograms per kg per minute. So 0.5 to 2 micrograms per kg per minute. This has a dopaminergic effect. So this has a dopaminergic, so meaning that it's going to be working on the dopamine receptors. And remember that you have these type of receptors that are present in the different parts of the body. And at this very low dose, it actually causes vasodilatation in the kidney. So it improves the renal blood flow. So this is our first dose. So this is what we call it has a dopaminergic effect. Then our second, which is going to be about 2 to about 10 micrograms per kg per minute. So this is at a higher dose. So this one here is going to be working pretty much on our beta-1 receptors. So this is going to be working on the beta-1 adrenergic receptors. So this has a beta-1 effect. Then our third dose which is a bit higher. So this is anything that's above 10 micrograms. So 10 micrograms per kg per minute. This is going to be having an alpha effect. So at this 10, you even have constriction of the blood vessels. At this 2 to 10, you have these effects that are working on the heart. So it means that if we actually now translate this to the effects that we see in the body, we're going to denote that somewhere around 1 to about 5 micrograms per kg. So make sure that you put the C in between, because if you just say mg, it's a different thing, totally different thing. So micrograms per kg per minute, this is what we refer to now as our low dose. So this is what we call our low dose. And if we're giving this as an IV infusion, what effects is it going to have? So number one, it's going to increase the urine output. So it's going to increase the urine output. Okay, that's one effect. And it's going to increase, so it's going to increase the renal blood flow, RBF. So it increases the urine output, it increases the renal blood flow. Then, so this is what we call our low dose dopamine. So those are the dosages that I want you to keep in mind, because this is what you may need to use during your patient rounds. This is what you may need to use in your emergency setting. Then secondly, we have now our medium dose, which is about 5 to 15. So our medium dose, which is about 5 to 15 micrograms. So 5 to 15 micrograms per kg per minute. So this is what we call our medium dose. So our mid dose. And again, if we're giving this as IV, what is this going to do? This is also going to increase the renal blood flow. So this is also going to increase the renal blood flow. It's going to increase the cardiac output. It's going to increase the heart rate. It's going to increase the contractility. So it increases the heart contractility. Contractility. So I want you to keep this in mind and follow me as I go on. I'll give you examples of how we do the calculations very shortly, but I want you to understand this very beginning principles, because they're very important when you come to these dopamine calculations. So that's our second with our medium dose. Now we move now to our third, which is pretty much our high dose. So here it's about 20 to 50. We shouldn't exceed 50 because there's a very high risk of arrhythmias with these. So our 20 micrograms per kg per minute. This is now our high dose. So in our setting here, I doubt as a junior doctor, you would be able to actually go as high as this. Maybe with consultation of your seniors, that's when you'll be able to actually prescribe these high dosage. So with this high dose, this actually just increases the BP. So this is going to be increasing the BP, but at this same high dose, it also has a vasoconstrictory effect, and there's a high risk of you developing tachyarrhythmias at this high dose, because that's one of the important side effects that we have of dopamine. So generally, when we're infusing this dopamine, we're going to be infusing. So remember, just a keynote to keep in mind is that when we're actually carrying out an infusion of the dopamine, we actually want to infuse it at about 1 to 4 micrograms per kg per minute. And this 1 to 4 micrograms per kg per minute is going to be at an interval of about 10 to about 30. This is kind of like a trial that you're giving for the patient, 10 to 30 minutes, and then we assess the response, and then we can actually titrate it up or titrate it down in order to assess this patient's response. This is in adults. Now, what about in pediatric patients? So remember that in pediatric patients, we just generally want to use a dosage of 1 to about 5 micrograms per kg per minute. And of course, this is going to be given as an IV. So we can actually increase this dose. We can actually increase this dose to about 5 to about 20 micrograms per kg per minute. And do not exceed, not to exceed 50. So we do not want to exceed 50 micrograms per kg per minute. So we don't want to exceed our 50 microgram per kg per minute. And remember, we want to titrate this according to the response. And we're going to be using this especially in the management of patients that are coming in with shock. So what are some of the indications and contraindications to which we're going to be using this dopamine? So number one indication is for patients that are coming in with hypotension. So if a patient is hypotensive, they have a low cardiac output, they have poor perfusion of the vital organs, dopamine is a very good choice to use. And in some patients that are in shock, for example, patients that are in septic shock, we also want to use our dopamine. Those that remain hypotensive regardless of you actually giving this adequate volume expansion, we want to use our dopamine for this. We also want to use our dopamine in patients that have cardiogenic shock. So in those that have cardiogenic shock, we generally want to use our dopamine for this. And then of course we also use it during resuscitation. So during our cardiopulmonary resuscitation, in some instances we tend to use our dopamine. So these are some of our indications that we're going to be using dopamine in. Now what about some of the contraindications that we're going to be using dopamine? Remember that dopamine has this positive effect on the cardiovascular system. It will cause vasoconstriction, it will increase the blood pressure, it will increase the heart rate to some extent, it will increase the cardiac output. Now remember that in patients that already have a high metabolic state, dopamine is contraindicated. So patients that are going to be having the pheochromocytoma, remember that pheochromocytoma is pretty much a tumor that's going to be in the adrenal medulla, which is going to be producing this catecholamine. So pheochromo, I think there should be a C here, cytoma. It's a contraindication. So here, these are contraindications, a big C over there. So pheochromocytoma, thyrotoxicosis, because of the thyroid hormones that are going to be produced. This is also going to be another contraindication. The third thing that's going to be there, if this person has tachyarrhythmias, that's also another contraindication that's going to be present in these patients that actually are supposed to be starting the dopamine, another contraindication. And someone who has ventricular fibrillation, so anyone that has VFib, these are going to be some contraindications of dopamine. So we generally want to also avoid dopamine in pregnant women unless if the benefits greatly outweigh the risks, but generally we do not want to give it in pregnant women. So what formulations do we actually have of dopamine? I'll show you a picture very shortly in the next slide. But before that, I want you to actually understand one thing. So when you look at the vial, they're going to tell you, they're going to write a certain thing on the vial. So they're going to say you have 1 ml will give you 40 milligrams, or they'll say 1 ml contains 40 milligrams of dopamine. Remember, this is in milligrams. You should take note. It's not in micrograms. Micrograms is mcg. So this is 1 ml will give you 40 milligrams. And remember that those vials, especially in our settings, we have the 5 ml vials. You must check with your hospital and see whatever you are actually getting. But at the hospital where I'm currently doing my practice, we have our 5 ml vials. So if 1 ml contains 40 milligrams of dopamine, how many mils are going to be present in 5 mils? So we say that's X. So this multiplies with this multiplies with that. So X is going to be equal to 14 multiplied by 5. So our X here will going to be equal to 200 milligrams. So keep this in mind. So for the concentration of dopamine that we have, or the formulation of dopamine that we have, our 1 ml containing 40 milligrams generally is going to be a dosage of 200 milligrams of dopamine. This is what we have on our ward. But again, not every hospital is going to be buying this exact same formulation. And again, even the same hospital can get another type of formulation. There's another type of formulation where 1 ml actually gives you 80 milligrams. And then you find that it's actually a 10 ml vial. So if it's a 10 ml vial, it means that that vial is going to be containing 800 milligrams of the dopamine. So remember that we can actually make the infusion. So there's a way in which we make the infusion. Okay, I'll talk about preparation in the next slide very shortly. But before I actually go this, remember that dopamine is compatible with a few solutions that we have in the hospital. We can have dextrose 5%. We can have our dextrose 10%. It's compatible with our dextrosaline, that's our DNS. It's compatible with our Ringer's lactate or lactated Ringer's. It's also compatible with our normal saline. But what I've seen it commonly being given, I've seen it commonly being given in DNS, I've seen it commonly being given in 10% dextrose. So generally this is how we make the makeup. So we can sometimes make a concentration that's 80 milligrams of dopamine, which is going to be found in 100 mils of this solution. So it's found in 100 mils of either one of these solutions, D5, D10, DNS, Ringer's lactate, or normal saline. That's one concentration that we can have. Second concentration that we can have is that sometimes we can get 160 milligrams, that's like double of the 80, in 100 mils. So 160 milligrams in 100 mils of the same fluid. Or we can say 320 milligrams in 100 mils. Okay, so if we reduce these concentrations, right? So this 80 milligrams, it in essence is going to mean that you have 0.8 milligrams. So we have 0.8 milligrams per mil for this concentration. Then we have 1.6 milligrams per mil. I'm just simply dividing both sides by 100. Then here, our concentration of this solution that we have is about 3.2 milligrams per mil. So it means that the concentration of the solution that you're creating, I'll show you how to create the solution very shortly. The concentration of the solution that we're creating can be as low as 0.8 milligrams per mil. This is very common in pediatrics, so it can even be at a higher dose of 3.2 milligrams per mil. So I hope you actually make sense of this. Then now here are the preparations of the dopamine. So here at the top of your screen here, as you can see, you have our 200 milligrams in 5 mils. So this already comes as a 5 mils. It contains 200 milligrams of dopamine hydrochloride. At the bottom here, we have 400 milligrams. Of course, this is a 10 mil vial. So it's 40 milligrams per mil. Then this one here at the bottom, this one should be 200 milligrams per 5 mil, just like this one on top. So these are the different formulations that we have. So you get a vial that's exactly like this. Okay. You should be able to know how much is present totally inside the vial. So this vial, for example, here consists, if this is a 5 mil vial, it consists of 200 milligrams of dopamine. So how do you make the preparation? So we get 200 to about 400. So if it's 200, you're getting one of these. If it's 400, you're getting one of these. If it's 400 with this one that's on top, you're getting 2 of them. Okay, I hope that makes sense. So you get 200 to about 400 micrograms, and you're going to be placing it in about 250 to about 500 mils of the fluid, of compatible fluid. And by what do I mean by compatible fluid? I mean our normal saline, I mean our dextrosaline, I mean our D5, our DNS, and our D10. So it means that, for example, I'll give you an example. If let's say we got 200 mils and put it in 250 mils. So we'll say 200 milligrams. Okay, so this is not in micrograms, rather it's in milligrams. Sorry, this is in milligrams, not micrograms. So 200 milligrams, we put it in 250 mils of our solution. Now, if we divide this, let's say we say how much will 1 mil give us? So 1 mil here will give us X. So our X in this case is going to be 200. So 1 multiplies by 200, X multiplied by 250, then you divide both sides by 250. So this is going to be 200 divided by 250. So if we say 200, we divide that by 250, that gives us 0.8. So our X is going to be 0.8. So as you can see, it takes us back to those concentrations that I was telling you about before on the previous page. You see this concentration of 0.8 milligrams per mil, so it takes us back to this concentration. So you know that if you take 200 micrograms, actually 200 milligrams of the dopamine vial, so if you take one of these vials on top and place it in 250 mils of fluid, you're pretty much going to be making the concentration of 0.8 milligrams per mil. So keep this in mind, because this is a very important concept for you to learn when it comes to the dopamine calculations. And in pediatrics, actually, we usually take about a smaller amount. We usually use about 50 mils of fluid. We take 150. So in pediatrics, so this can be done in adults. So in pediatrics, we take about 150 milligrams of the dopamine, and we place it in about 50 mils of compatible fluid. So if we take 150 milligrams and place it in 50 mils, so if we say again, how much will 1 mil give us? So 1 mil will give us X over there. So if we say X multiplied by 50 and 1 multiplied by 150, so our X is going to be equal to 150 divided by 50. Then again, if you divide 150 divided by 50, so that gives us our higher concentration of 3 milligrams. So this is going to be 3 milligrams per mil. Same thing as what I was talking here, is still below this threshold of 3.2. So that's what we use in our setting. Sometimes we can even go as high as 200 milligrams, and then we add it to 50 mils of our compatible solution. So let me give you an example now and see how exactly we're going to be giving the orders to the nurse, such that you are able to tell the nurse she's able to input these things in our infusion pump. So there are certain few things that you really need to know when you're coming to this calculation. So one thing that you really need to know is the weight of the patient. Okay, so that's one thing that you really need to know. So let's say that we have this 55 kg. So this is an example here of 55 kilograms. And this patient is in shock. Okay, you have tried giving your IV fluids. The IV fluids are not really working, and then you want to now escalate to inotropes. So remember that our dose that we require, so we know the weight. The next thing that we want to note is, what is the dose required for this patient? So our dose required, which is our dose R. So this is going to be at 10 micrograms. Let's say we're giving it at 10 micrograms per kg per minute. So 10 micrograms per kg per minute. So this is our dose that is required. This is how much. Remember those dosages I told you at the beginning for low dose, medium dose, and the high dose? So we're giving it at 10 micrograms per kg per minute. Let's say now the nurse makes a solution and tells you the available solution that we have, our available solution is, let's say she has added 800 milligrams in 500 mils of solution. So she has added 800 milligrams in 500 mils of solution. If we actually reduce this even further, we divide, let's say, the 800 divided by 500, so it gives us about 1.6. So this is about 1.6. This is about 1.6 milligrams per mil. I think I already did the calculation in the previous slide. So if you're confused about how I got to the 1.6, please rewind the video and you'll be able to establish. So 1 mil is going to be equals to X, then X multiplied by 500, 1 times 800, then 800 divided by 500 will give us 1.6. So that's about 1.6 milligrams per mil. Keep this in mind. So how much is this patient going to receive? Okay, so we'll say the dose to receive. So how much is this patient going to receive? Remember, our dosage is at 10 micrograms per kg per minute, and our weight is 55. So you say our dose, which is in our micrograms per kg per minute, multiplied by our weight, which is 55 kg. And remember, the kg here cancels this kg. So this kg here cancels that kg. So if you multiply 10 by 55, that gives us about 550 micrograms per minute. So this person must receive 550 micrograms per minute. But remember, the first conversion factor that I told you, or the second conversion factor, is that 1 hour is going to give you 60 minutes. Okay, 1 hour is going to give you 60 minutes. So in 1 minute per minute, how much is this person supposed to receive? 550 micrograms per minute. So how much should they receive in an hour? Because you want to find, the thing that we're looking for here is, we want to find how many meals per hour should this person receive? That's what we want to find, because this is what we're going to enter into the infusion pump when it asks you for the mils per hour that you are going to be entering. So in 60 minutes, how much are they going to receive? We say X over there. So X multiplied by 1, then 60 multiplied by 50 or 550. So our X is going to be equal to 550 multiplied by 60 minutes. Okay, so this gives us 33,000. So this is going to be giving us 33,000. So this is in micrograms per hour, because you're going to be giving this over 60 minutes. So this is how much you're going to be giving in 60 minutes, 330 micrograms per hour. So in 1 hour, this person is supposed to receive 330 micrograms. But remember, 330,000 rather micrograms. Now remember, this is 330 micrograms. We want to change it to milligrams, because our concentration here is given us in milligrams. Even this concentration is in milligrams, it's not in micrograms. So we want to change this micrograms to milligrams. So remember again, the next conversion factor that I want you to remember is that our 1 milligram is going to be equal to 1,000. So this is going to be equal to 1,000 micrograms. So 33,000 micrograms. So 33,000 micrograms is going to be equal to X. So X multiplied by 1,000, 33 multiplied by that, then we divide both sides by 1,000. So this is just simple ratios. If you do not understand this, then I am sorry. You really need to revise your math. So 33,000 divided by 1,000. So this gives us 33 milligrams per hour. But we're not yet done, because we want to find out how much they're supposed to receive, the mils per hour that they're supposed to receive. What's our concentration that we have? This is our concentration that we have. Okay, in about 500 mils, we have 800 milligrams. So in 500 mils, we have 800 milligrams of dopamine, but we want to give this 33 milligrams in 1 hour. So how many mils do they need per hour to receive the 33 milligrams? So we say 33 milligrams is going to be equal to X. So then we simply solve for X, and that will give us the mils per hour. So if we say 33 multiplied by 530, we divide both sides by 800, that will give us our X. So our X is going to be equal to 500 multiplied by 33 divided by 800. So it means that our X, to give us our final answer, is going to be, this is about 20.625 mils per hour. So if we round this off to like 1 decimal place, we're going to set our infusion pump to 20.6 mils per hour. And this is the order that you're going to be giving the nurse. You're going to tell the nurse, get 800 milligrams of dopamine, add it to 500 mils of normal saline, and let it run at 20.1 mils per hour. And that's enough information to give the nurse to actually work with. And I hope you actually understand this. So you can actually pause the video, work throughout this example, and actually see if you do follow. So we'll go on to the second example, which is now a pediatric patient. So now in this pediatric patient, let's say our weight this time is now reduced, because our pediatric patients are weighing much less than our adult patients. So let's say now this time it's a 24 kg patient. And remember that this is like, let's say, an 8-year-old, okay, and they're in shock. Okay, there's an 8-year-old that's in shock, and 24 kg. Now our dose, remember our dose, if they're in shock, we do not want to exceed 5. So let's say we put it at 5 micrograms. We put it at 5 micrograms per kg per minute. So we put this at 5 micrograms per kg per minute. That's our dose. Now, what's our available concentration? Our available concentration. Like I said, in our setting here, sometimes we may add the 150 micrograms in 50 mils of the compatible fluid. So let's say we have 150 milligrams, not micrograms rather, 150 milligrams in 50 mils. That's our concentration that we have. If we actually reduce this, is about to 3. So this is about 3 milligrams per mil. So that's our reduced concentration. Now we want to find how many mils per hour are we going to enter into our infusion pump, because we know the weight of the patient, we know the dose, we know the concentration that's available, but now we want to know how many mils per hour should this fluid be running at. So let's first calculate how much drug this patient must receive. So the drug to receive, or the dose in which this patient must receive. So it's going to be that 5 micrograms again. So 5 micrograms per kg per minute multiplied by our weight, which is our 24 kilograms. And remember that our kilogram cancels the kilogram there. So if you multiply 5 by 24, that gives us around 120. That gives us 120 micrograms. So this person must receive a total dose of 120 micrograms per minute. Now remember how many minutes are in an hour? We have 1 hour giving us 60 minutes. So this gives us 60 minutes. Okay. And if in 1 minute we're receiving 120 micrograms, how many? So if in 1 minute we're receiving 60 micrograms of a drug, or rather 120, not 60. We're receiving 120 micrograms of the drug. How much drug is this patient supposed to receive in an hour? So in 60 minutes, how much drug would they receive? We say this is X. So our X, we solve for X by 1, 60 by 120 there. That gives us now our 7,200 micrograms in an hour. So this is per hour or per 60 minutes. So we're receiving this amount. Now remember, our second conversion factor is that 1 milligram, because our concentration is in milligram per mil, so I want to change this micrograms to milligrams. So 1 milligram will give you 1,000. Will give you 1,000 micrograms. So how much will 7,200 micrograms give you? We say that's X. So if we solve for X, we simply divide our 72,000 divided by our 1,000. So that gives us 7.2. So this gives us 7.2 milligrams per hour. Okay. So what's our concentration here? We come here to our concentration. So 50 mils is going to give us 150 milligrams. But we need to give 7.2 milligrams in an hour. So how many mils are we going to give in that hour? So we say 7.2 milligrams of the dopamine to give us X. And then we simply solve for X. So 7.2 multiplied by 50. So 50 multiplied by 7.2. And then the answer you divided by 150. So if you divide all this together, it gives us 2.4 mils per hour. And this is the order that you're going to be giving the nurse, that take 150 milligrams of dopamine added to 50 mils of normal saline or Ringer's lactate or D5 or DNS. Then after that, let it run at 2.4 mils per hour. I really hope this actually makes a lot of sense. So before I actually go any further, I just want to talk about the concept of IV drip rate. So there are two types of drips that you can actually have, the drip stands, actually the infusion sets rather, not the drip stands, but the infusion sets. So we have what are known as macro drips. Macro meaning big. So these are known as macro drips. So now these ones are going to be giving these large volumes of fluids very quickly, and you can infuse a lot of fluids at a higher rate. So these ones give you an infusion rate of about 10 to 20 drops per mil. Then we have those that are micro drip, which we often see. These macro drips are very common on the wards, but the micro drips, we often see them in pediatric patients in the NICU for the neonates because they give very small amounts and precise amounts of fluids. These ones give roughly around 60. They can go as high as 60 drops So as high as 60 drops per minute, or per mil rather, not per minute, 60 drops per mil. So keep this in mind as well, because there will be a time when you actually are able to calculate how many drops per minute the fluid should run. But here is the formula if you do not have an infusion set. So our IV drip rate, which is going to be calculated in drops per minute, how many drops this patient actually needs in a minute. We say our volume of the fluid that we're going to give, and this should be in mils. The time in which we actually should give this fluid, which is in minutes, and then the drop factor, whether you're using, so this is what we refer to as a drop factor, whether you're using a macro drip or we're using a micro drip. So our drop factor. So this one is going to be in drops per mil. Okay, I'll give you a practical example. Suppose we want to push in about 500 mils of normal saline in 30 minutes in a patient with this infusion rate that is giving us 20 drops per minute. So if we have 500 mils, then this 500 mils, we want to divide it in 30 minutes multiplied by our drop factor, which is going to be our 20. Okay, so this cancels this out. Then we have our 50 multiplied by 20. So our 50 multiplied by 20, that's going to be 1,000. This divided by 3. So 1,000 divided by 3, this gives us about 333. So this person is about 333 drops per minute. That's how we calculate our drop factor. And I really hope that this has helped and will help you actually learn a bit more and be much more interested in these drop factors and these infusion rates on the ward. So here's an example that I want you guys to actually work out, and actually leave the comments in the comment section below and see if you have actually worked it out. If you get it right, I will respond. If you get it wrong, I will respond and ask you how you did your calculation and correct you. So suppose we have a patient that's in shock and our weight is 82 kg. Then our dose at 5 micrograms per kg per minute. Then our concentration of our fluid is 400 milligrams in 250 mils. 400 milligrams in 250 mils. So 400 milligrams of dopamine in 250 mils of normal saline. So I want us to work out how many mils per hour you're going to order the nurse to actually give this dopamine. So please work this out, comment in the section below, and I will leave the pinned comment of the first person who gets it correct. I really hope you enjoyed this video on dopamine calculations. If you did, consider subscribing to the channel. I know it was a very long lecture, but I hope it was worth it. My name is Dr. Moses Kazevu. Do not forget to subscribe, drop a comment, drop a like to show some support to the channel, to Zambia and beyond. Until next time, bye-bye.